Hello class, my name is Winston Ambrosio and I'll be talking about psilocybin in my presentation, also known as magic mushrooms. So what exactly is psilocybin? Well, psilocybin is a substance that can be obtained from different subtropical areas of the world, including South America, Mexico, and the United States. Along with psilocybin, this is what gives magic mushrooms their psychedelic effects. We'll go into more detail on the effects in a later slide. Let's go into the history of psilocybin. First off, the use of magic mushrooms has been documented for thousands of years and was said to be used for medicinal and ceremonial reasons. Mushrooms became popularized in 1961 due to mushroom enthusiast R. Gordon Watson, who was featured in a photo essay of Life magazine. 4 years earlier in 1957, Watson stumbled upon an indigenous tribe while on vacation and brought back a sample of psilocybin to give to Swiss chemist Albert Hofmann, who famously discovered LSD. Hoffman developed a synthesis for the drug and performed clinical experiments for the next 2 decades. It was showing promising potential for treatment of a broad range of psychiatric disorders such as alcoholism, schizophrenia, and OCD, among many. Despite the long history and ongoing research into its therapeutic and medical benefits, the Controlled Substances Act of 1970 listed psilocybin as a Schedule I drug for its high potential for abuse and no currently accepted medical use. However, as we'll learn in more in the later slides, there's evidence that heavily supports the contrary. Pharmacokinetics studies the absorption, distribution, metabolism, and excretion of medicinal products, and we'll go into brief detail on the features of psilocybin. 50% of psilocybin is absorbed following administration, and it is almost uniformly throughout the body. Psilocybin breaks down into metabolites following ingestion, those being the four listed, which I'm not even going to try to pronounce. Following oral administration on an empty stomach, it's significantly detectable in plasma within 20 to 40 minutes. Plasma can be tested via sweat, tears, and blood. Effects vary from person to person and difficult to categorize because the effects of the drug can be affected by various factors such as environment, state of mind, anxiety, etc. Psilocybin produces profound changes in consciousness and perception, such as sensory enhancement, sense of time change, real or imagined objects appear to be moving, personal insight and reflection, and excited mood. Lastly, the effects last for about 4 to 6 hours and peaks within the second and third hours after ingestion. Since the experience differs from person to person, the long-term effects are largely psychological. Some of the mild side effects include dilated pupils, elevated blood pressure, and increased heart rate. However, it might be worth to note that these also may be side effects of emotional intensification. Other effects include nausea, increased sweating, numbing, and tremors. An important note is that it may cause current psychological symptoms to seem worse, such as anxiety attacks, paranoia, and mood swings. So I have to admit, this was the hardest slide to find information for because there seems to be so little information on adverse health risk related to this drug. However, I did find some shocking information. According to a study by the Global Drug Survey, psilocybin was considered the least toxic of drugs known and had the lowest rate of emergency room visits, stumping both alcohol and marijuana, which are two very common substances of abuse. In accordance, a study by Nutt et al. Ranked it the third safest of all drugs, and in another study by Johnson et al., they concluded that no evidence of such potential neurotoxic effects with the prototypical classical hallucinogens, i.e., LSD, mescaline, and psilocybin. In Carbonaro et al.'s study, however, out of 1993 surveys, 11% felt that they put themselves or others at risk for harm, 2.6% behaved aggressively, and 2.7% had to receive medical help. Additionally, 7.6% of people sought treatment for psychological symptoms thereafter. Nonetheless, 84% of participants endorsed benefiting from the experience. Even if there is a seemingly low-risk nature, there are still risk factors and consequences. De Jong et al. Reported 2 young men were motivated to auto-mutilate after ingesting mushrooms. It was also noted in the article that they had been using alcohol and cocaine, and it seems that the mushrooms reacted with them in a negative fashion. Mueller et al. Reported another auto-mutilation case where the user commits suicide shortly after taking mushroom psilocybin. There is also a risk for quote-unquote bad trips, as those diagnosed with a personal or family history of mental illness may be at risk for latent psychological issues emerging. This might lead to a distorted perception of the world and, furthermore, therapy. In addition, the combination of other substances, can also spell potential danger for the user. Psilocybin is primarily administered via oral ingestion, but an alternative is by treating the mushrooms like tea. Steeping them in hot water and drinking it is another way of administering the drug. In this final slide, we're going to look at some of the ongoing research on psilocybin as a treatment in various psychological disorders. Ross et al.'s study looks at the use of psilocybin in aiding anxiety and depression in patients with life-threatening cancer. One of the findings highlighted was that psilocybin produced immediate, substantial, and sustained improvements in anxiety and depression, and led to decreases in cancer-related demoralization and hopelessness, improved spiritual well-being, and increased quality of life. Johnson et al. And Bogenschutz et al.'s studies look at the use of psilocybin as an aid to current treatment programs for smoking cessation and alcohol dependence. Each journal shows some promising evidence that the use of mushrooms under clinical scientific handling may contain many qualities that can be used for treatment.